Next up is Ric Price, who's going to talk to us about the clinical consequences of recurrent asymptomatic infections. Ric.
Good morning, everyone, and thank you to Alan and Rowley for putting this together and also having the bravery of inviting me back onto the podium. I'm under strict instructions, no inappropriate jokes, and respect humility. So here we go. We haven't had enough icebergs, really, because this is all about the iceberg, and it's the elephant in the room, because it has fundamental implications for the way in which we're going to go about control and elimination. And these are the icebergs that you've seen, and a lot depends upon, as we heard this morning, how you define one, what's asymptomatic, and two, what is parasitemic or subparasitemic or subpatent. And that depends upon your methodology, and it depends upon your quality assurance on that methodology. So RDTs will allow you about 100,000 per microliter per mil, 50,000 for microscopy. Probably a good microscopist could get down to 25 per microliter. Small volume PCR, 50 microliters of blood, about 1,000 per mil. Large volumes, now Malika presented yesterday, Malika and Wong, showing 1 mil of blood with DNA, about 100 per mil. And if you use the RNA, which is what a lot of people are doing now, you can go down to even lower, about 10 per mil. What on earth does all of these very small quantities of parasitemia mean? And that's what I'm going to base it on. So there are going to be a lot of pictures of icebergs, and out of deference to Joel, I've got the hippopotamus there for you. And there'll be a few of those as well. So I'll talk a little bit about it. I was asked to talk about asymptomatic, but I don't actually view asymptomatic as being philosophically different from subpatent. They're ends of a spectrum, or they're part of the spectrum of biomass and parasitemia. This is some data that we did from Papua Indonesia, and you can see that actually over 70% of people were asymptomatic at the time. A simple definition, just parasitemic now, febrile now, or a history of fever in the last 24 hours. But 70% at that time were classified as being asymptomatic. And you can see that the age stratified relationship of that varies between PF and PP, and lots of people have shown that. When we actually look at the PCR versus microscopy, and this was done with small volume PCR, 100 microliters of blood, you can see that our prevalence goes from about 5% up to 25%. So we multiply by 4 times if we have it by small volume PCR. This is data from Francois. 6 times if you start using the high volume PCR. And so where is the edges and the limits of that iceberg? We've managed to do a study from Papua where we have treatment-seeking behavior, cross-sectional surveys, and hospital large scale surveillance, and this is just in press at BMC Medicine, and we can quantify roughly what we think of the number of cases of malaria parasitemia out there, of which, as I said, only about 32% have a fever at that time, okay, crude definition. Of those, 7.3% end up in hospital, 23% of those have severe disease, and then there's this little nugget of deaths down the bottom. Now, those are your asymptomatic parasitemias, and those are your symptomatic parasitemias. If we now contemplate what would happen if we did subpatent, it's a lot more. It's a bit like one of those pictures with the moon against the earth, against the sun, against a big red giant. So are we dealing with a big red giant, or are we dealing with the sun? And of course, the limits of that, again, are going to depend upon your quantification. So having that defined, and we're talking the same language, is absolutely crucial. Bad microscopy, as we know, is inherent within the system, and we haven't got proper QA assurance for our PCR yet. So that's an upside down iceberg, just to fit in with those kind of levels. And over time, what we have are clearly episodes of symptomatic illness where we come across the horizon, depending upon what level we're using, and then every now and again we have bouts of transmission with an increase in gametocytes. And you can think evolutionary-wise, the parasite was designed to sit there ticking away, transmitting, and then every now and again increasing its parasitemia so that it could have gametocytes. Whether that fizzles out with a bit of host immunity or whether that's maintained for a long period of time, we don't really know. That down here, 8 diagnoses, Wendy's already covered that. She covered it beautifully. What you really need is longitudinal cohorts to see whether people are coming up or not. Just cross-sectional prevalence isn't really ideal. And there's a whole load of complexities out of that I'm sure most of you are aware of. So it's about parasite biomass and that relationship, however we determine it. And higher parasite biomass gives you a greater risk of fever, gives you a greater risk of anemia, severe disease, and treatment failure. Interestingly, as I'll show you, it gives you a lower risk of gametocytemia. So over here is a simple plot on the x-axis is your parasitemia down to 100 per microliter, and then on the y-axis is your risk of being febrile, and you have this kind of sigmoid plot that comes up here. The shapes are different for the different parasites. Vivax tends to have a lower pyrogenic density, but of course that's also going to depend upon your host immunity. So let's talk about malarial anemia. Quite nice. Ellen, you've already done all of this, so I'm just reiterating what Ellen has said much more eruditely, but it's complex, and there's various different issues. When each bout of malaria you hemolyze between about 8 to 14% of your red cell mass. But it's not just about the acute hemolysis, it's about the hemozoin, it's about the oxidative stress, it's removal of parasites in the spleen, and then you've also got impaired erythropoiesis. So a complex array, and again varying between the two different parasites. So this is a very large study that we published last year, Nick Douglas analysis, which is beautifully done, by him, not by me, I hasten to add. Which uses fractional polynomial regression models, a huge number, 2,200, in a database that consists of over 1 million patient events. And you can see that on the y-axis is hemoglobin, and here you get the burden in the hospital of people coming in with febrile disease. Now, of course, that's not all malarial attributable, as Wendy would point out, but these are people who are febrile, who've got a hemoglobin, and you can see that actually if you have no malaria, there is a drop in the first year and then there's a recovery, but clearly, especially at the young ages, there's a large pull down from being symptomatic parasitemia, such that in the first few years of life, a 15% risk of having severe anemia defined as a hemoglobin less than 5. Now this is a very interesting plot down here. 5,000 people died in the hospital over that period, over a 10-year period, and we can look at the relationship between death and hemoglobin. And you can see that on the y-axis is death up to 10%, 20%, 30%, 40%. So there are two parts of this curve. It begins to take off at 7 grams per deciliter. And that in the Western hospitals, when we would transfuse in an intensive care setting, we never see hemoglobins down this low. But if you're in a poorly resourced place, you get these extreme anemias, which are extraordinary, 1 or 2 or 3 grams per deciliter. And I'm sure some of you working in Africa and other endemic areas see this. But it's appalling to see someone go into high output cardiac failure. I've seen that with a 30-year-old man who was walking down the corridor, high output cardiac failure with a hemoglobin of 1. So in between that is a more interesting area between about 2, 3, and 7, whereas you get decompensation and co-infection, I'm sure, or viral illness or some event, comorbidity, that is actually knocking you off. Now what's interesting here are the different lines. So this red line is falciparum. The green line is Vivax, and the blue line is no malaria. So we hypothesize that the reason behind that is there's an acute drop with falciparum, causing a rapid decompensation, and that's associated with a higher morbidity or mortality. Whereas with Vivax, I think it's more of a chronic process which allows you to compensate and has a different mortality scale. We've also done cross-sectional surveys in this area. These are unpublished, but you can see that the shape of the curve, this is hemoglobin and just a histogram. You shift backwards about 1 or 2 grams when you are parasitemic compared to not parasitemic. This is done by microscopy. And there's no difference between being febrile and not febrile. So if you look at asymptomatic carriage, does pull down. Most of these were about 70% of these were asymptomatic. And if you plot that out on a fractional model with age on the x-axis, you can see again asymptomatic carriage is also pulling down your hemoglobin, particularly at the young ages. So here you've got the risk of anemia here. This is hemoglobin, so the risk goes up to, I can't read that, what does it say? 20%. No, it's not 20%. Can't read it. 20% at the young ages. The gametocytemia, Rolly, what's that? No, it's an iceberg lettuce. Sorry. Risk of PF gametocytemia. There is some beautiful literature on this from the experimental models, and when I was more erudite, I'd be showing you pictures of that. Instead, I'm showing you pictures from my thesis, which is now also considered the old literature, unfortunately. Shows my age. But here, very interesting, if you come in, now these are people coming in with febrile disease, acute malaria, and the risk of gametocytes on presentation. And you can see that actually being afebrile and having a low parasitemia gives you almost a threefold increased risk of gametocytes. So presumably this is a biomass time dependency, the long-term holding of the parasitemia and then popping up with a gametocytemia when they become febrile. Whereas actually the risk of developing gametocytes after treatment is dependent upon whether you had this to begin with, the gametocytes to begin with. Anemia is a very important factor, also presumably as a marker of sustained or prolonged pre-admission parasitemia and the like. So here you can see that actually on this scale, the long-term subpatent parasitemies, I don't have the data on this for subpatent, I don't think it exists yet, but subpatent parasitemia are also more likely, I think, to be producing gametocytes, although that's speculative, and Chris is raising his eyebrows. Here's the ultimate asymptomatic infection, which is the hiplozoite of vivax, and you can see here with the transmission dynamics of vivax, following infection are out here. Most of these are asymptomatic infections. Nearly all vivax carries, if you've got asexual, will also carry a degree of sexual gametocytes as well. And most of these are asymptomatic, but clearly the relapse is a huge generator of vivax transmission dynamics. What about malaria and pregnancy? Well, there's some lovely studies, and Francois reminded me of this one the other day, by Rose McGreedy, massive study, risk factors associated with miscarriage, symptomatic malaria, but even asymptomatic malaria in this part, double the risk of smoking. So 2.75 asymptomatic parasitemia. And we had a similar analysis from our work in pregnancy where we were also screening people, and low birth weight was associated with severe anemia. So we showed this problem with severe anemia causing acute mortality, but also within pregnancy is an important determinant of low birth weight, which in itself is a very important public health concern. So of these, only 35% of these women were febrile or had a fever, and actually the peripheral parasitemia was associated with stillbirth and neonatal death. So another indication of the detriment of asymptomatic parasitemia. So conclusions. In terms of symptomatic, yes, they're causing anemia, transmission, potential, the febrile parasitemias, recurrent infection. I'm glad someone gone into a lot more detail in terms of bacterial co-infection, which is hugely important, particularly when you have anemia, risk of miscarriage and severe disease. Asymptomatic malaria, well, I think there's very good evidence for most of these. In fact, that's wrong. I think that probably asymptomatic can cause severe disease by its anemia. So that should probably be a plus if you sustain that. Subpatent is a little bit harder to define in terms of a lot of this, and we really look forward to seeing proper prospective studies which are going to be able to define this. But I think there is actually evidence certainly of anemia, and I haven't presented that, but we've got it coming up on a preliminary analysis. And also we know that many of those have ability to transmit. Some of these other ones are yet to be defined. And of course, the rationale behind that is going to have huge implications for how you go about tackling it. One final thing, again, I'm going to stress that none of this is going to be solvable until we actually have some proper QA and methodological systems that allow us to define the bounds of the supernova. Thank you very much. Caught up on time.
Thank you, Rick. Have we got any questions?
Yeah, thank you very much for this very interesting presentation. I just wonder, I didn't hear you commenting on transmission intensity. I mean, how, asymptomatic, asymptomatic, subpatent, how it affects, transmission and all of those risks, depending on transmission intensity.
Yeah, absolutely. I mean, that is a huge subject in itself, and I just tried to contain myself to actually defining whether asymptomatic was important. Okay, so if we go back up to our circles, here, what I should have had is the line, there should be a similar line here, which would also go in terms of how you define things and also in terms of host immunity and background transmission potential. So you're absolutely right. That is the relationship that we need to determine, and that will also vary by age, by transmission, by immunity, and we need to define that as well. So good point. Thank you.
Okay, thank you.